Now, here comes the other topics. We invite Professor Bancha for the topic of the state of the art, the meniscal allograft transplantation.
Yes, good afternoon. Thank you, KK Wong. I'm Dr. Bancha Chernchujit. I'm from Thammasat University Hospital, Thailand. My topic is the meniscus allograft transplantation, the state of art. So thank you, my four fellows, for preparing the document. So meniscus allograft transplantation just started in Thailand this year, so it's quite new. Also, thank you the tissue bank, Professor Visit, Professor Supanit, and Professor Chalit for helping us. Professor Rapon and Professor Pongsak, these two guys is the starter and promote me to try to do this. Dr. Kong Pop, he's my ex-fellow and now he's working in the Red Cross Society. So he's the one who donated himself to doing the allograft transplantation in Thailand. And this is the team. Yeah. So we have the tissue bank from Red Cross and Sirirat Hospital many years ago by Professor Yongyut Saranet and Dr. Lapin. Yeah. And this is our previous past president also promoting us. So this is a very long history, and also this is our senior advisor of the Thailand Orthopedic Sport Medicine. You see many persons involved in this project. So this is the first time meniscus transplantation in this world. It was first time in 1999 in Munich, Germany, Ludwig Maximilian University. The pioneer, Dr. Verdong, he's a pioneer of meniscus allograft transplantation, and he's the one who inspired me to perform this in Thailand. If you see the trend of the meniscus transplantation in the world is becoming more and more popular over the past 10 years. These are the trends by country. The Western side tend to use the meniscus allograft without bone, but the Asia Pacific side tend to use the meniscus allograft with bone bridge or bone plug. Back in May 2025, we did the first perform meniscus transplantation in Kadaver in Thammasat University before we doing that in the real patients. And these are the early pioneer in Thailand. Yeah. So the knee arthroscopy in Thailand has become so far during the past 20 years. I think we are not behind the world. But the thing that we are feel guilty is that we cannot perform the meniscus transplantation. And if you look at the meniscus, medial side, lateral side is different. The medial side C-shaped, less mobile and larger in size, while the lateral side is circular, mobile, and cover more cartilage. So challenge in meniscus surgery is that you always delay the treatment. And in the past, we did a lot of meniscectomy. So we did a lot of high tibial osteotomy. You look at the X-ray, it look very perfect, right? But you look at the joint is still narrow. So that means you did not collect the intra-articular pathology. The cartilage damage or arthritis chain is still ongoing. Although we did a very nice osteotomy, you look at this, right? Yeah, we cannot open the joint. A lot of patients are waiting for meniscus transplantation, such as post-meniscectomy or chronic bucket handle tear. So the destiny of this patient is also arthritis. And I think we can keep preserving cartilage in this patient with meniscus transplantation. So these are the indications for the meniscus transplantation. The patient should be young, less than 50, non-functional meniscus, knee alignment appropriate or collectible, ligament intact or reconstructible, no significant articular cartilage defect. These are the contraindications, include full thickness cartilage loss or before BMI more than 35, inflammatory joint disease, and previous septic arthritis. The surgical techniques include all soft tissue technique, like on the left side, or you can use the bone bridge or bone plug. The different technique applied in different locations of the meniscus for the lateral side and the medial side. Okay, on the lateral side, they prefer to use bone bridge. On the medial side, prefer to use soft tissue or bone plug. But from the meta-analysis study, they found that the soft tissue and bone, there has no clinical significance, no difference. If you look at the bone plug, the meniscus survival at 7 years is around 81%. And this is a soft tissue. Survival is nearly the same, 80% at 10 years. The meniscus transplantation show improved knee stability, about AP translation and rotational stability in vivo study using the navigation in 80 cases. X-ray is a good tool, but you still have error about 7 to 10%. So the gold standard nowadays is the MRI. So the error is about 4 to 8%. So meniscus transplantation, many times you need to combine with other surgeries such as the cartilage surgery, ligament reconstruction, or the osteotomy. So let's see the case scenario. This is the first patient we did, 37 years old. He has chronic meniscus tear and he has a radial tear. He went to many hospitals and everyone said you need to do high tibial osteotomy. Yeah. So he said he's too young to do osteotomy and he come to see me like the fourth surgeon. Right. Look at his knee. His knee have some villus alignment. Okay, this is his MRI. So I discussed with him that you are the good candidate to do meniscus transplantation. About the osteotomy, I will decide when I get in. If your cartilage is bad, I will do additional osteotomy for him, right? So when we get in, we found that he has bad meniscus, okay, chronic meniscal tear, and we make the all soft tissue technique. So we use the all soft tissue technique using the all inside repair, right? We did not use any implant. We just use the suture, okay, meniscus to the meniscus, okay? So the key point is that the size should not be too small. You should be the same size or you should be bigger. If you get bigger, you can trim a little bit and you can pull the root into the tibia, okay? So this is his outcome. Yeah, right now it's about 4 months. Yeah, he's doing well. He can walk well and the joint space open, the alignment getting better. He can start to do the exercise, right? So we did the MRI at 4 months. We found that the patient have very nice healing of the meniscus. You can see the healing in the bone plug also good, right? And anterior posterior. The side is a bit bigger, but the patient, I think he's quite happy. The joint line pain is gone. The second patient have meniscus bucket handle, both medial and lateral side. So I did ACL reconstruction, both meniscus repair, but I'm failed on the lateral side. The medial side, I can fix it well. So he's still young. I discussed with him that we do meniscus transplantation for him, right? So after the surgery, the patient doing well. Right now, we follow the patients. His range of motion is coming better, right? So we're waiting for the result. So the third patient, he has ACL torn and very bad instability. So I did ACL reconstruction, LET, and also the meniscus transplantation, right? So that's ACL or inside reconstruction, and also LET, and medial meniscus transplantation. So ACL healed nicely, and also the meniscus also good, right? This is about 3 months, yeah. So the last patient is the 56 years old. He's a bit old. Yeah, he have joint space narrow. His cartilage is bad. So I did the high tibial osteotomy together with the meniscus transplantation for him, right? That is his meniscus, okay? So we did meniscus transplantation first, followed by the HTO, okay? So that is after the surgery, yeah. His meniscus is good. So in conclusion, the meniscus allograft transplantation, I think that is a new thing for Thailand and it's quite challenging. That may change the prognosis. I think we did a lot of mistake in the past. We delay surgery. We miss a lot of meniscus root, meniscus radial tear. And I think if you early diagnose, you can delay the need for arthroplasty in the future. And thank you. We need a lot of collaboration. Thank you so much.